important session of you can only improve what you measure. And am I audible and my slides are visible?
Sure.
Yes,
Uh,
it is
yeah,
done.
yeah,
Audible.
Yes,
yeah. And it's changing, slides changing.
yes,
Yes,
Yeah,
change.
yes,
yeah. That's great. So the important message goes that when we have tried to control the blood glucose, the effort to monitor has started. All of you have watched the good old days when we used to do a urine glucose testing by the Benedict's test, and that brick red color in the biochemistry laboratories has been done by almost all the diabetologists who have reached the highest peak of their career. The most important message follows. Then come the HMBG, the self-monitoring of the blood glucose. Then came the A1C, which told us intermittently in 12 weeks' time the monitoring pattern. And of course, now the continuous glucose monitoring, which covers through time in range, time below range, and time above range. And we'll see what exactly they mean to us. The evolution of glucose management, all of you know. And in this picture, just I'll show you how the blood glucose, the thing which is plotted here is a CGM, and the thing which is down here is a SMBG. The glucometer readings, the black spots are the glucometer readings, and the readings which has come above the range and the below the range are the CGM readings. So this is undetected hypoglycemia. This is undetected hyperglycemia. So in the tracing, the blood glucose can go above, can go below, and the CGM captures and provides up to 288 glucose readings each day, which detects these fluctuations, which is practically not possible by SMBG or A1C. So A1C has a poor sensitivity in diabetes diagnosis to change the epidemiology of diabetes. And A1C has significant differences in various ethnic groups which are poorly understood and characterized. All of you know that using the same biomarker for the diagnosing and the monitoring diabetes might have negative effects, and the level of A1C predicting future retinopathy, nephropathy, the population is not well established. That's less than 6.5 has association of these complications of micro and macrovascular nature. And using A1C will delay the diagnosis in diabetes up to 60% of incident cases. We took 6.5 for the diagnosis, but neither for the diagnosis nor for the monitoring, it comes out very promising. And from the trials like ACCORD, ADVANCE, and BADT, the very important findings are the intensive and the standard glycemic control which we have followed. And if you see this results of this trial, it cannot apply to the results broader population, the patients of type 2 diabetes, and trials didn't show benefits in reducing cardiovascular risk, intensive versus standard treatment. And if you see this landmark trials, the many lacuna in monitoring come to the picture. That's only related to the CGM, lack of CGM, and deficit of a continuous monitoring for which this has been advocated, which takes around 288 readings in a day. So let us see about the time in range. We mean by telling TIR percentage of time that a person spends with their blood glucose levels in a target range. And the range will vary depending on the portion, but the general guidelines suggest starting with a range of 70 to 180 milligram per deciliter, which is standardized and advocated. So time in range can also be understood as the hours per day spent in range. If it is 50%, you can understand that 12 hours per day, the person is well controlled blood glucose that's fluctuating between 70 to 180 milligram, and half of the day the patient is well controlled. So you can see the different pictures of CGM telling you time in range, time above range, and time below range. 0% time in range is one in the first picture, 25% time in range, 1/4 time, 50% time in range, half of the time, 75% and 100% time in range. The whole fluctuation is in between the 70 to 180. So the prediction of the long-term diabetes complications as per the landmark diabetes control and complication trial, the DCCT, the strong association with the risk of development or progression of the retinopathy. Let us see one by one the complications and the association. You can see the percent time in range. This is less than 10% to more than 70%. And the frequency of retinopathy comes down from 58% to 5%, along with the increasing time in range. So directly the complications, microvascular and macrovascular, they comes down with increasing percent time in range. And here the strong association with risk of development of microalbuminuria. You see the percentage time and range less than 10% to more than 70%, and frequency of microalbuminuria from 27% to 3%, the percentage has come down. So the summary is more is the time in range, or more time the person is within good control, there are better chances the microvascular complications like the retinopathy, like microalbuminuria will come down. And the association of time in range as assessed by the CGM with diabetic retinopathy is divided to 4 quartiles, less than 51, 51 to 71, 71 to 86, and more than 86. This is Q1, 2, 3, 4. And it was graded as non-diabetic retinopathy, mild NPDR, the moderate NPDR, and then vision-threatening diabetic retinopathy. And here you can see the mild, moderate, and the vision-threatening diabetic retinopathy, the prevalence as per the different quartiles, it comes down. So that the summary is prevalence of diabetic retinopathy by severity as a function of time in range quartile. So better is the control or time in range, better lower is the incidence of diabetic retinopathy, which has already been shown by me. So patients with similar A1C values could have distinct glucose profiles. All of you realize that. And for instance, one patient could have long episode of both hypoglycemia and hypoglycemia, whereas another could have a stable glucose pattern throughout the day. By contrast, the TIR illustrates the time spent in the preferred glucose range, which is an intuitive way of assessing the glucose control, but it provides important information not captured by A1C. A1C shows shame in both the category who are above the range or below the range, but the CGM only can detect those times. And then this study suggests that the time in range as an intuitive metric of the glycemic control for both patients and clinicians is associated with the prevalence of diabetic retinopathy. So this is the relation of all-cause cardiovascular mortality in patients with type 2 diabetes, a prospective cohort study. Here the TIR was measured with continuous glucose monitoring at the baseline, and the participants were stratified into 4 groups as more than 85%, 71 to 85%, 51 to 70%, and then less than 50%. I have told you the different quartiles, and this is in relation to a macrovascular complication, the cardiovascular mortality. And you can see the all-cause mortality and cardiovascular mortality with cumulative survival, and this is by different levels of time in range are different. So more is the time in range, less is the mortality, the cardiovascular as well as the all-cause. So in conclusion, the study found a strong and graded inverse relationship between time in range and the risk of all-cause and the CVD mortality among patients with type 2 diabetes. So the findings suggest that the patients with diabetes should be encouraged to aim for the achievable higher TIR to reduce the risk of adverse clinical outcomes, although the goal should be individualized. In elderly, in fragile patients, we have a higher goal that goes beyond in doubt, but this time in range is very broad, 70 to 180, and more time somebody spends in range, less is the chance of macro as well as microvascular complications, what you saw in these trials. And the patient-centric approach of time in range encompasses above range and the below range. And the normal glucose range for individuals without diabetes is reported between the 3.9 and 7.8 millimole, and the upper and the lower limit of determining the time in range are not synonymous with the upper and lower limits of the normal glucose values. So 70 and 180 are much broader than our normal diagnosing limits. So the choice of upper and lower glucose thresholds for determining TIR is partly pragmatic. So here you can say the more than 13.9 millimole is very high and less than 3 is very low. And in between comes the low and the target in range and the high range, which is around 14%, 21%, 54%, 6%, and 5%. And that tells how much of hour the person has spent in a good control and how much in the bad control. The lower limit of the determining time in range, which already have discussed here, reflects the upper limit of the definition of the hypoglycemia. And then and the 70, which we have already talked here, is the upper limit of the hypoglycemia, and the point at which the counter-regulatory hormone release generally begins to occur. And the determination of time above range, the hypoglycemia is subdivided into level 1 and level 2, level 3, and level 4. And then here you see the level 1 is 10.1 to 13.9, level 2 is 13 more than 13.9. And the determination of the time below range, the hypoglycemia is subdivided again into the level 1, 3 to 3.8, and level 2 is less than 3. So if you take these two levels, time above range and time below range, glycemia and hypoglycemia further classified. Subdivision, the hyperglycemia into the different levels based on the consensus recommendations comes, the low glucose level, the decreased symptom awareness, increased risk of severe hypoglycemia, increased mortality risk comes in this category, and the adverse consequence of the glucose levels come in this category. And the real life challenge with the SMBG are important. Inconsistency with the testing of the blood glucose level come inadequate time to detect the patterns, handwritten logbooks during the short office visits they come. So that's why this TIR, TAR, and TBR universally followed gives us a very important conclusion of probability of a patient developing the chronic complications, maybe micro or macrovascular. Here, what Dr. Dale was telling about the continuous glucose monitoring and the flash continuous glucose monitoring, continuous provides the real-time measurement of the glucose, 5 or 1 minute interval, and the alert patients when the glucose levels are too low or too high, they send the alarms and the alerts. And CGM is a tool to help personalize the diabetes treatment plan. But the flash continuous glucose monitoring, the relatively new glucose monitoring system, so resembles established CGM, and the first 14 days factory calibrated flash glucose monitoring allows quick identification of the poor glycemic control to inform the treatment decisions. So the CGM helps in modifying the diet and lifestyle, and you can have a rough impression of modifying the diet into lifestyle in Indian diabetic patients, the different percentage, the frequency of response of subjects to the CGM, the change in the time of the diet, and then exercise, the relaxation technique, and then the sleep, and the in the chart basing on the CGM data. And the use of CGM results in significant improvement of the control. And if you may say A1C, if you say in type 1 and type 2 diabetes, the CGM based approach has much better control in monitoring than a SMBG based or the A1C based control. And the real time CGM improves the glycemic control, and the use of CGM during the pregnancy improves the glycemic control in women type 1 type 2 diabetes, lower the infant birth weight, and reduce the risk of macrosomia. It's a very important use that we follow up CGM in pregnancy and diabetes and achieve a better control, which is very important not only for mother but the child also. And the CGM and the different techniques monitored for the glycemic variability in type 2 and type 2 diabetes. You see the hypoglycemic spikes and the hypoglycemic spikes are very important, and it's useful in assessing glycemic variability, the mean average standard deviation, the J index, coefficient of variance, the low blood glucose index, the average daily risk range, the mean amplitude of the glucose excursion, mean of the daily differences, and continuous overall net glycemic action. So the clinical indications, somebody who has a brittle diabetes or the poor metabolic control have high glucose variability. And with hypoglycemia unawareness and also with the gastroparesis, the pregnancy and critically ill patients, the CGM contributes. And lot many studies have concluded the beneficial effects. In the interest of time, I'm not going to the details. The pregnancy and the remote monitoring, many studies have corroborated with in a day, within day glucose variation seen with the CGM technology that may be missed in relying the SMBG or A1C alone. And the CGM review recent studies demonstrating improving the glycemic control. The systems are safe and effective for type 1 and type 2 and improve quality and glycemic control, and then very inexpensive and can be done in a remote rural setting as well. Gives you much more information than SMBG and the A1C. And the consensus recommendations is currently, I have already discussed about the different levels and the target without going to the details of the monitoring charts. I'll summarize my topic because it's time. The use of time and range enabled the diabetologists, the endocrinologists, and the diabetes educators to analyze more than one component of the glycemic control. And one of the possibilities for the future is the combination of various metrics trying to better define glycemic control. Gathering more than one metric is an attractive idea when analyzing diabetes control and might be used more frequently over the next years. And the recent consensus recommendations suggest the TIR more than 70%, the TBR is less than 3.9 millimole per liter, less than 4%, that's around 70 milligram percent, and less than 3 millimole per liter, less than 1% for most individuals with type 1 or type 2 diabetes. Although the targets should be individualized and the different targets should be considered for the older and the higher risk individuals, pediatric population, and the pregnant woman. So the 70 to 180, which is taken as time in range, at least 70% should be the time in range in a day, and the time below range and the time above range should be as minimum as less than 4% and less than 1%. So this concludes the presentation and TIR, TAR, and TBR, and I'm sure you will be sticking to this very scientific method of monitoring and achieving a good glycemic control and preventing complication by keeping the person in TIR more than 70%, that is between 70 to 180 milligram percent. Thank you everyone for the listening. Thank you, Professor Das. Thank you, Dr. Alok Anungo. Thank you, Team 9th NUCD, for the opportunity.